This is Dio. Last time we learned about the general concepts such as position, height, diameter to consider in the planning stage. Today, I will explain the method of positioning the implant according to the environmental factors in the oral cavity. There are 8 environmental factors to consider in the planning stage. The first is the initial stability. In order to achieve successful initial stability, enough torque value must be obtained when placing the implant. And the surgeon must consider the bone density and follow the drilling protocol according to that bone. In the case of soft bones, such as D3 and D4, it needs to be under-drilled. And in case of hard bone, it needs to be placed lower to avoid too much torque by using a profile drill. All protocol is developed by Dio, and you can apply it to all cases. In the case of a sinus lift, it must be planned so that at least 3 mm of fixture thread is fixed in the residual bone. In addition, as illustrated in the photo above, it must be planned to achieve initial stability in the cortical bone at both the upper crestal part and at the bottom of the maxillary sinus. This is referred to as the bicortical bone contact method. Generally, fixture is planned so that it is positioned at the bone level, or 0.5 mm lower. If it is situated too deep by any chance, the bone might get in the way of the abutment later on while connecting the prosthesis. Therefore, the top level should be set at similar position compared to the neighboring tooth or dental root level. Also, always try to situate the fixture within the periosteum, that is, in the cancellous bone. This is because there is more abundant supply of blood in the cancellous bone than in the compact bone. This means there are more osteoblasts in the cancellous bone, which can be substantially helpful in the secondary stability. If the bone width is narrow, it must be planned so that there is at least 1 mm of bone remained in the buccal side. One of the biggest differences between the surgery with and without incision is the bone absorption rate. There are lots of articles that confirm this. If a patient had 1 mm of bone left in the buccal side before the surgery, when they went through the surgery with incision, it was noticed that the bone had been absorbed after some time. However, after the surgery without incision, it was noticed that bone had not been absorbed even after some time. From the prosthesis perspective, the screw hole direction for the anterior teeth needs to be directed toward the palatal and lingual side. It is because the prosthesis could be pronounced unaesthetically if the screw hole direction is toward the buccal side. Posterior tooth needs to be planned by arranging the tooth virtually so that screw holes are situated at the center of the occlusal surface. It is also advisable to plan the implant after checking the CT images to avoid placing in the narrow ridge or in the areas with bone defects. This is because the success rate is higher if the implant is placed in a location with sufficient bone width. If the implant is planned in a location with a defect, there is high probability of problems occurring, such as deviation from the path or degraded initial stability at the time of the actual procedure. Also, for prosthesis fitness, align the path of anterior and posterior as much as possible. I have told you the importance of the safety distance before. There needs to be at least 1.5 mm between the implant and the neighboring tooth, 3 mm between two implants, and 2 millimeters between the bottom of the implant and the alveolar nerve. Always plan to place implants according to the rule of the safety distance. If there is inflammation around the neighboring roots, widen the distance from that tooth a little more to prevent implant failure. And also, there are 2 tubes that enter the dental root apex for each tooth. These tubes are neural tubes and blood vessels. If the position of the implant blocks, cuts, or presses on the blood vessel by any chance, it will prevent supply of blood to the neighboring tooth, with the possibility of generating discoloration or abscess in the tooth. Next is immediate loading after extraction case. In general, it can be predicted that our alveolar bones will be absorbed of about 3 millimeters in the buccal and about 1.5 millimeters in the vertical area after the extraction. Therefore, the fixture can be placed at the expected location where the alveolar bone absorption can occur, and the location of the bone can be predicted after the extraction. And even if the alveolar bone is absorbed a lot, it is important to match the bone level of the adjacent root because it becomes difficult to make prosthesis or for maintenance when the fixture is lowered too far. And the most important part is that in the case of an inflamed tooth, the implant must be placed after the inflammation is thoroughly removed. Even if the initial stability is good, it can be predicted that if the inflammation is not removed thoroughly, the fixture will eventually fail. Although it may vary from case to case, in cases where the maxillary sinus lift is required in the maxillary posterior tooth extraction case, the hydraulic lift may not be possible during the DIOnavi procedure. The head of the extracted tooth, the crown part, may be large, so that the pressure of the membrane tube may not be applied to the gums, or the cell line may leak between the extracted roots, so the sinus membrane may not be lifted. For this reason, if the implant has to be placed immediately after extraction, and it requires sinus treatment in advance, other treatment methods such as the crestal or lateral approach should be available. If the bone width is insufficient and you plan to do GBR, secure the bone in the lingual so that GBR can be done on the buccal side. And if you don't plan on doing GBR, it's better to expose threads at the palatal side. This is because the gums in the palatal area are made of a very thick connective tissue, which can protect the fixture from food and germs from invading. Below is the planning method for a case with a GBR already done. Depending on when the GBR was done, the bone may have already been converted into an autogenous bone, or it may still be in the midst of being converted. Therefore, it is important to check when the bone graft has been done. If it is difficult to know when it was placed, it is recommended that the fixture be placed in the autogenous bone and not in the place where the bone was first transplanted during planning. Likewise, if you plan so that the fixture's thread can be fixed about 3 millimeters to the autogenous bone lower than the place where the bone was transplanted, initial stability can be obtained during the procedure and can reduce the possibility of failure. That's everything about how to use basic knowledge in clinically diverse cases. Thank you for listening. This was Dio.